I think students, are you ready? Shall we start the discussion?
Yes, sir. Good evening, sir. Yes, sir. Yes, sir.
Good evening. Okay. Why can't you discuss the case? I will share the screen with you.
Yes, sir.
Is my screen visible to you?
Yes, sir, it's visible.
Okay. Gaurav, we'll start.
Good evening, sir. My voice clear, sir?
It's very clear.
Okay, sir. Okay, sir. Good evening, sir. We'll start now, sir. Sir, 29-year female, sir, came to OPD with chief complaints of exertional breathlessness for 3 months, tiredness for 2 months, 1 episode of giddiness on exertion for 1 month, and edema of both lower limb for 7 days, sir.
Okay. What are the conditions that you should suspect? 29-year-old female coming with these symptoms.
Yes, sir. Yes, sir. The first 29 years. The candidate first is pulmonary artery hypertension.
Yes, pulmonary arterial hypertension can be a possibility. Yes. Other possibilities.
Sir, there is 1 episode of giddiness on exertion.
So you have to think of conditions where there, yes?
LVOT obstruction.
Yes, very good. LVOT obstruction, dynamic as well as fixed obstructions, aortic stenosis, hypertrophic cardiomyopathy, yes.
Oh, sir, AS in 29-year female I am not considering.
I agree with you that fixed obstruction is very unusual in females, but when you consider the differential diagnosis, you can always think that also is a possibility. Okay, right? Yes.
And sir, any cardiomyopathy? Cardiomyopathies.
Any arrhythmias? Exercise-induced arrhythmias?
Tachycardiomyopathy.
No, tachycardiomyopathy is due to tachycardia giving rise to myopathy. But can it be sixth sinus syndrome?
Sixth sinus syndrome in this age, sir, I am
unusual because it's but unusual. Okay, can it be an arrhythmia which is precipitated by exercise? Any QT prolongation syndrome? Can it give rise to exercise-induced arrhythmia? The only problem is that the patient is symptomatic only for the past 3 months. Okay, now let's go to story.
Cardiomyopathy, sir. Cardiomyopathy.
Cardiomyopathy usually okay. Exertional giddiness may be due to arrhythmia. Okay, cardiomyopathy can be considered. Yes, that's also is a possibility. Very good.
So, this
29-year-old female, can it be a postpartum cardiomyopathy?
No history of recent that we have to see. So there's no history of any this childbirth.
That we do not know because only the complaints. These are the chief complaints. So let's go to the history part. Okay.
Yes, sir. So yes, a history of presenting illness. So congenital, I am not congenital also, but 29 years I was.
No, congenital, if a 29-year-old female presenting with some symptoms, what is the congenital heart disease that you can think about?
AST
can be considered. AST is the one. Yes, AST can be considered because AST patients may come with symptoms maybe in the 3rd decade. They may have exertional breathlessness but most of the time symptom is palpitation. Here the main symptom is exertional breathlessness. And also at the age of 29 years, unless the patient has started developing significant pulmonary arterial hypertension, severe pulmonary arterial hypertension, giddiness is not a usual symptom. But if you are considering any congenital heart disease, one heart disease that you can consider is atrial septal defect.
Yes, sir. Yes.
Okay. Do you think that can be Epstein's anomaly?
But sir, abstinence have a biphasic, abstinence highly, and I'm not. Only 3 months history, sir, and no history of.
Very low in the list, if at all you are considering. Only thing that you can consider is that if the patient abstinence normally started developing a complication like right heart failure or started developing arrhythmias, then these patients can become symptomatic. If you want to consider unusual possibility, you can include abstinence anomaly also. The patient can have some symptoms of breathlessness associated with right heart failure, RV dysfunction, or it can be partly related to development of arrhythmia like atrial fibrillation, or maybe due to atrial flutter, which can make the patient deteriorate, and the patient may be presenting with the symptom of exertional breathlessness. Okay, now let's go to story and then we'll.
But the age is somewhat not for abstinence. Generally, they would have 10 years or.
The abstinence anomaly, they can develop symptoms depending upon how severe is the displacement and how severe is the
regurgitation.
RV dysfunction. So that is still possible, but one episode of giddiness on exertion is not a common symptom of abstinence anomaly.
Yes, sir.
A rheumatic heart disease?
Which one will you consider?
Sir,
But
right-sided together with right-sided.
But symptoms of 3 months only, so I am not considering symptoms of 3 months only. So.
Well, I think we have only heard the symptoms. Let's go to the story part and we'll discuss further. Okay, right? Yes.
Okay, sir.
Oh.
The history of presenting illness symptoms started 3 months ago when she felt mild exertional breathlessness while carrying out her one-year-old daughter. Symptoms deteriorated quickly within 2 weeks, and she started feeling breathless on normal routine activity. Class 2 symptoms, she has gained 10 kgs of weight after her delivery. Although that symptoms is...
and thought.
Okay, sir.
And
yes. And thought that symptoms is due to that. She consulted a local general practitioner who after examining told her that there is nothing serious and asked her to lose weight. Her symptoms deteriorated and she started becoming breathlessness or minimal exertion, and past 1 month she's class 3 symptoms. She was started becoming breathless or minimum exertion for past 1 month. Class 3 she was comfortable and has no history of PND. She had 1 episode of giddiness on exertion 1 month ago. Did not lose consciousness. Sorry. No history of cough or hemoptysis. No history of palpitation or cardiac pain. No history of upper limb claudication. She consulted a cardiologist who said she had a heart disease and carried on investigations, including echo, and based on that, she was started on medication. She had minimum improvement. She was feeling tired even with mild exertion. For the past 7 days, she had observed mild reduction in urine output associated with reduction in urine output associated with this. She developed edema of both the limbs. She is on 4 medication, of which 1 is a diuretic. Past history, she gave birth to her first child 1 year ago. No symptoms during pregnancy or after delivery. No history of rheumatic fever in history. No history of hypertension, diabetes. No history of congenital heart disease. Parents alive. Both are hypertensive. No diabetic. Siblings are healthy. Habits, no adverse habits. Restarted her normal menstrual cycle 4 months ago. Yes,
Okay.
sir.
Now, based on the symptom as well as the presenting illness, what are the possibilities that you can consider? The doctor who examined her first time told her that she is perfectly normal and there is no heart disease. What does that mean?
Means that she had no valvular disease. She has no, because auscultation he was not able to pick any murmurs.
Yeah. So that's the most important thing. Whenever a doctor has examined and told a patient that she is normal and she has got a heart disease, then most likely is that the patient did not have any murmurs. So it is usually the general doctor practitioner picks up a heart lesion by detecting a murmur. So if there is, it obviously means that this doctor did not pick up a murmur, and that is why he told that most likely her symptoms may be related to the weight that she has gained. So we can reasonably conclude that she is not having any disease where there is a loud murmur. Okay, right? Yes.
And so there is no history of PND also. So MS is
Sir,
high.
endomyocardial fibrosis can be considered. There is only right-sided involvement.
So this is a right-sided problem. So we have to think of the various right-sided problems. So what are the right-sided problems that you can think about? Hello.
Yes, sir.
What are the right-sided problems that you can think about in this patient?
So PH still I am thinking of PH leading on to all these things.
Okay, that's one possibility. PH maybe primary pulmonary artery hypertension leading to all these problems. Okay, right? Yes.
Other thing,
Thromboembolism.
constrictive pericarditis and RCM, recessive cardiomyopathy.
Yeah, restrictive cardiomyopathy, especially right-sided endomyocardial fibrosis. Is it possible?
Sir, right now incidence is less, so and age.
And also she had an uneventful pregnancy.
Yes, so.
And also it's not a very common thing with somebody is presenting within 1 year of her delivery, presenting with features suggestive of significant cardiac disability. Bit unlikely, but when right-sided disease, we can always think of RV endomyocardial fibrosis also. Okay, anything else? Can it be a AST?
AST, but only 3 months and tiredness 2 months. It can still be, AST can still be there. Okay.
Yeah, AST can be considered, and only thing is that the main symptom is breathlessness and not exertional palpitation. Palpitation is the more common symptom in a volume overload condition like atrial septal defect.
Some noise is there.
Oh, can somebody mute themselves so that the noise is not disturbing the class?
Rishabh, can you please mute yourself?
Okay, right, yes.
Sir, still postpartum cardiomyopathy, but the definition is 6 months post. So that
Postpartum cardiomyopathy, what is the definition?
Sir, in the last trimester to the 6 months post delivery. So
6 months post 6 months post delivery. Yeah, no. Usually, what is the time gap in which you consider peripartum cardiomyopathy?
Sir, last 5 months and post delivery 1 month.
Gaurav, what is your opinion?
I remember last trimester and 6 months post delivery.
No. It is 1 month prior to delivery and 5 months after delivery.
Oh, so 6 months duration total.
6 months duration, out of which 1 month is before the delivery and 5 months after delivery. So if the patient develops features of dilated heart and heart failure over a period of 6 months, extending from 1 month prior to delivery and 5 months after delivery, that can be classified as peripartum cardiomyopathy. So in this patient, she gave birth to her baby 1 year ago, and she's symptomatic for the past 3 months. So strictly does not fall under the category of peripartum cardiomyopathy, but that also should be considered, because it's not a strict watertight compartment that it is from 1 month to 5 months. But there can be always minor variation. So in this patient, I think we should definitely consider a possibility of peripartum cardiomyopathy also.
Yes, can it be sarcoidosis leading on to all this? We have seen few cases of sarcoidosis leading on to heart failure, sir.
Yeah, sarcoidosis can give rise to heart failure, and it can give rise to arrhythmias, and it can also give rise to conduction abnormalities. But the presentation of exertional giddiness on exertion is a bit unlikely for sarcoidosis. Sarcoidosis can present, mostly we look for sarcoidosis when the patients are presenting with unexplained arrhythmias, or can also develop cardiomyopathy-like picture also. But sarcoidosis can, yes?
Pulmonary embolism.
Yeah, very good. As pulmonary embolism should be definitely considered. because
pregnancy hypercoagulable state and after pregnancy.
Yes. Pulmonary embolism giving rise to recurrence episodes of pulmonary embolism, not a huge one, but multiple episodes of pulmonary embolism giving rise
pH we
to.
have already done, sir. pH we have already considered. So
The pH secondary to pulmonary embolism. Okay, right. Yes. Anything else? Do you think that this can be
carcinoid syndrome? Carcinoid syndrome?
Carcinoid syndrome.
No history of flushing and other things. No history of flushing, nothing. So we'll not. No history of flushing.
RV cardiomyopathy?
Yeah, that we have already considered. RV endomyocardial fibrosis we have already considered. And do you think that carcinoid? Carcinoid, there was a suggestion from carcinoid.
No, sir. No history of flushing and other things, sir. And there's no history of diarrhea, nothing. So I am not considering carcinoid.
From the history, there is no clue for us to think of carcinoid. Okay, right. Yeah. Any other condition?
I think we have a 6, 7 now, sir. 6. We have 6 DD.
Okay, out of which in the order, how will you give importance? First one will be?
First one is pH. Causes can be.
Yes, first one is pH. Second?
Second, sir, dynamic LVOT obstruction.
All right. There was no murmur detected, but then still that can be considered dynamic LVOT obstruction. 3.
Third, RV, restricted cardiomyopathy.
Yeah, restricted cardiomyopathy. Or do you think that Epstein's anomaly and AST also should be considered?
Down in the list. Down in the list. And RV cardiomyopathy can also.
Okay, so these are the few conditions that you will consider.
Dilated cardiomyopathy. Dilated
cardiomyopathy. And we should consider peripartum cardiomyopathy also, dilated cardiomyopathy of the peripartum nature, because she had given birth to baby a year ago and she has developed symptoms for the past 3 months. Even though it does not fall strictly within that definition of peripartum cardiomyopathy, there can be minor variations, and then this can also be considered. Yes, okay. Okay, shall we go to physical findings? Yes.
As on examination, mildly dyspneic, no cyanosis, no clubbing or pallor, mild edema present up around both the ankles, no dysmorphic features, no skeletal abnormalities. Respiratory rate is 18 per minute. Sir, SpO2 I am not able to see here. SpO2. SpO2 I am not. SpO2, such oxygen levels.
Oxygen level. I don't think that is taken. Okay, right. Yes. Don't worry.
Okay. Pulse rate 90 per minute, regular, low volume. Vessel wall not felt. All pulses felt normally. No radiofemoral delay. Low volume pulse, sir. That is a blood pressure is 110 by 90 millimeter of edge in right upper limb. JVP, both A and B waves are prominent.
Okay.
And A wave is 12 and B wave is 14. And mean JVP is 10, elevated above the sternal line in normal with normal Y descent.
Okay. How do you make out A waves and B waves in the jugular venous pressure?
Sir, we have to time with the heart sound or with the carotids.
Okay. How do you time it?
Sir, the wave coming with the carotid is A, sir. And after.
No, sir, wave coming before the carotid is A.
Yeah, the wave coming before the carotid is A. What is the wave coming with the carotid?
V wave.
No.
C wave.
C wave is the one which occurs with the carotid. A wave before carotid, C wave with the carotid, and V wave after the carotid.
After.
Okay. And by looking at the wave, how will you make out whether it is A wave or a B wave?
Sir, V wave will have this. V wave will be more sustained.
V wave will be
Sustained and.
Sustained. How will you make out by looking at the wave pattern? How will you make out whether it is A wave or a B wave?
So descents are more prominent in JVP. The descents are more prominent.
That is right.
So, and
anybody, how will you, by looking at the wave pattern, can you make out whether it is an A wave or a V wave?
Sir, A wave has a sharp rise and sharp fall,
Very good.
whereas V wave has slow rise and slow fall.
So rapid fall. Fall is rapid.
Rapid fall. Okay.
So there's a wave has got a sharp rise, sharp fall, and V wave has got a slow rise because it's a filling wave, followed by a sharp fall. When if the fall may not be sharp, if there is a, what are the situations in which you may not get a sharp fall in a V wave? Is Egnath?
RVMI, sir.
RVMI. Okay. What are the situations where you can get a V wave is the Y descent? The Y descent is slow.
Tricuspid stenosis.
Tricuspid stenosis is very good.
One is, sir, this Y will be absent in tamponade. Y will be absent in tamponade.
Okay, and why is absent in tamponade? Why the Y wave is absent in tamponade? Mechanism?
So there is no diastolic filling. So why is that?
There is no diastolic filling. Why there is a, which wave is more prominent in cardiac tamponade?
X wave.
X wave. X descent is very prominent, while the Y wave becomes very much reduced, and also it may completely disappear. What is the mechanism? Why it happens? Why there is no Y descent in cardiac tamponade? Anybody? Saroj, would you like to try?
Because systole is the only duration when heart gets filled, sir.
In the tamponade.
In systole, heart gets filled. What do you mean by that?
Not, sir.
In the cardiac tamponade, it is the only, sir, during the systole, the blood is going out. So filling, sir, filling will also be, sir, just after that only. Sir, but sir, there will be, sir, the amount of blood which is coming in and going out is fixed. So, sir, it will only during the X wave, the blood is going out, and immediately after that.
What did you say in X wave? Blood is?
Sir, going out, sir.
Initial part of the X descent, but yes, in the second half is actually the second half of the cardiac systole is actually the V wave.
Sir, so
sir, in systole, systole is the only duration when the atria gets filled up, sir.
Okay, right, that's right. But during systole, when the atria gets filled up, there will be a V wave. But then why there is no Y descent? What are the hemodynamic changes during cardiac tamponade? During when Y descent occurs in which phase of the cardiac cycle?
Diastole, sir.
Diastole.
One second. Hello. Good evening. I don't think, Manjunath. I am taking a online class. I'll give you a call as soon as I finish the class. Okay. Okay. So what happens during systole? What happens during diastole? In the as far as the pericardial pressure is concerned. As far as the pericardial pressure is concerned, what happens to the pericardial pressure during systole and what happens to the pericardial pressure during diastole?
During systole, pericardial pressure will decrease.
Yes, why?
Sir, because sir, the total volume is fixed together with the tamponade during pericardial fluid. So, sir, during systole, the volume of the heart is decreased.
Yes, very good.
And that's why pericardial pressure will decrease.
Very good. During systole, the pericardial pressure will be very much reduced. That is because the blood is pumped out of the heart and the total volume of the heart comes down, and that will result in a lower pericardial pressure. Okay. During diastole, what happens?
Sir, as the volume of cardiac chambers increases, the pericardial pressure will increase.
Yes, pericardial pressure will go up. Yes. So, what will be the effect of pericardial pressure on the intracavity pressures of the various chambers?
So venous return will decrease.
Venous return, there will be some degree of venous return, but what will happen to the intracardiac pressures?
Increase.
It will increase. The intracardiac pressures will increase, and that will result in actually a complete obliteration, because you cannot have a descent there, because the intracardiac pressures will increase and the descent will be completely obliterated. I will repeat. During systole, when the heart is smaller in size, the pericardial pressure is low. This will help in the filling of the atrium. When the diastole starts, the volume of the heart goes on increasing. That will result in an increase in the pericardial pressure. When the pericardial pressure goes up, you cannot have a descent, because pericardial pressure is transmitted to the chambers of the heart, and that will result in absence or very minor descent or a very minor negative wave. Wide descent cannot take place as it happens in a normal person, because of the fact that as the heart increases in size, the progressive increase in the pericardial pressure, which will be transmitted to the cavities of the heart, and there will not be, it will be transmitted to the right atrium also, to the atrium also, and hence there cannot be a wide descent. Wide descent is because of the progressive increase in the pericardial pressure as the heart gets bigger and bigger during diastole, and progressively increasing the pericardial pressure, and hence there cannot be a wide descent. The descent cannot happen because the pressure progressively increases. Why there is a wide descent? Because the right atrial pressure goes down. But in a patient with during systole, during diastole, when the heart expands and the volume of blood, volume of fluid all around the ventricles are displaced, it will go towards the atrium and it will compress the atrium, and the atrium cannot have a wide descent. Atrial pressure still remains elevated, so you will not have a wide descent. Wide descent is, so if you are asked a question why there is no wide descent, the explanation is that during systole the ventricle is small in size, the intrapericardial pressure is low. During diastole, as the ventricle increases in size, the intrapericardial pressure goes up. The pericardial fluid is displayed from around the ventricle towards the atrium. The atrial pressure, thereby preventing the atrial pressure to go down, and hence you cannot record a wide descent. That is because the negative pressure cannot be recorded in the atrium. Okay, right? Yes, go ahead.
Sir, here mean GVP is raised, so mean GVP is about.
Why the AV? What are the conditions in which you get a prominent AV?
So first,
conditions in which you can get a prominent AV.
the tricuspid stenosis.
Very good.
And
right heart failure, pulmonary heart PH.
No, right heart failure is not the correct answer. No.
Pulmonary stenosis.
PH can occur, sir.
No, any condition associated with the RV hypertrophy. Yes, you're right. Whenever there is a RV hypertrophy, why there can be a prominent AV?
End diastolic pressure of RV increases.
The expression of RV increases because of the atrial contraction. For
Because
that, hemodynamic explanation. Why should
atria
the
needs to
atrium
contract
contract
against atria needs to contract against non-compliant right ventricle.
Oh, all right. You have to give the initial part. See, initially the ventricle, the hypertrophied ventricle is less compliant, and hence the rapid filling as well as the diastasis, slow filling phase are reduced in a patient with right ventricular hypertrophy. So that will result in a large volume of blood remaining in the right atrium, and the right atrium has to contract powerfully to empty its contents into the right ventricle, and which also contributes the proper filling of the right ventricle. And because the right atrium contracts powerfully, that will result in a prominent AV. So any condition associated with the reduced compliance of the RV can give rise to a prominent AV in the neck, which is usually associated with right ventricular hypertrophy, as can occur in pulmonary stenosis and pulmonary arterial hypertension. Okay, right. Third. Other conditions where there can be prominent AV in the neck.
Due to reverse burning effect leading on to.
Yes, right. Reverse burn effect also sometimes can give rise to, not reverse Burnham, the Burnham effect itself. Why did you say reverse Burnham effect? Reverse Burnham effect is right ventricle bulging onto the
LV.
left ventricle. Here the LV, if it bulges into the right ventricle, it can encroach on the cavity of the right ventricle, and that can give rise to a wave in the neck. Very good. Burnham effect. 3, 4.
The pulmonary hypertension.
That we already mentioned. Pulmonary artery hypertension, pulmonary stenosis resulting in pulmonary right ventricle hypertension.
Tricuspid atresia or myxoma.
Yes, very good. Right atrial myxoma. Right atrial myxoma can give rise to sometimes prominent AV if it falls onto the tricuspid valve and partly blocks the tricuspid valve. Very good. Yes. What else?
Sir, can unruptured sinus compressing the
yes, that can especially, yes, especially the posterior sinus, if it dilates unruptured, it can encroach on the tricuspid orifice and can give rise to something like the tricuspid valve obstruction, giving rise to tricuspid prominent airwaves in the neck. Okay. So these are the few conditions in which you can have prominent airwaves in the neck. To recapitulate: 1, tricuspid valve abnormalities. Example: tricuspid stenosis, tricuspid atresia. 2, non-compliant right ventricle associated with right ventricular hypertrophy, pulmonary arterial hypertension, pulmonary stenosis. 3, one more condition we forgot to mention. Another is in patients the RV infarction. Sometimes you can get a prominent because so the RV becomes non-compliant, and then the A wave can become prominent. Then you can consider patients with a right atrial myxoma, right atrial tumors, myxoma, lipoma, whatever it is, sometimes can obstruct the tricuspid valve and can give rise to prominent airways in the neck. And of course, any outside structure, for example, unruptured sinus of valve aneurysm, especially the posterior sinus aneurysm, can bulge onto the tricuspid valve and can give rise to something like a tricuspid stenosis, giving rise to prominent airwaves in the neck. So these are the few situations where you can get the prominent airwave in the neck. Okay, yes.
So V wave
conditions associated with prominent V waves in the neck. Gaurav.
Yes, increased filling of the right atrium, sir. Increase filling of the right atrium.
Okay. Now tell me the conditions where you can get.
Yes, sir. Tricuspid regurgitation, tricuspid regurgitation.
Very good.
Then RSOV to RA.
Very good.
Then ASD.
ASD with MR.
ASD with MR, very good.
Then so Gerbold VSD.
Gerbold VSD, very good. I think these are the few conditions which you can get a prominent V wave in the neck. So to repeat, tricuspid regurgitation, any condition where there is a large volume of blood coming to the right atrium, like ruptured sinus of valsalva into the right atrium. You can get in a AST with the mitral regurgitation or a LV-RA shunt. All these can give rise to prominent V waves in the neck. Okay, right. Yes. Okay, right. Yes. So the A wave is 12 centimeters, V wave is 14 centimeters, mean GVP 10. So from the picture that there is a patient is having a most likely the patient is having RV dysfunction or patient may be in a right heart failure. Okay, right, go ahead.
And so one more, there is some condition leading on to some RV right ventricle right ventricle dysfunction only. Yes, sir. Right ventricle dysfunction.
Yeah, right, RV dysfunction. Yes. Okay.
That's coming on to precordial examination. Apex beat is seen and felt in the fifth left intercostal space, 1 centimeter outside the mid-clavicular line. Is forceful, sir. When traced medially, apical impulse continuous with the parasternal impulse. No thrill or sound palpable.
What does that mean? What does that mean when traced medially? The apical impulse is continuous with the apex. So how will you differentiate apex from RV, LV and combined?
Sir, rotation, yes, sir. One is that RV impulse it can be medially traced. RV impulse can be medially traced up to the epigastric.
How will you make out whether the apex is formed by the right ventricle or is it only a pure left? By palpation, how will you make out whether the patient is having only RV dilatation, RV plus LV dilatation, or only LV dilatation?
So one is the rotation, some medial rotation or lateral rotation of the.
No, but that's a theory part. You tell me clinically what will you find? You have to tell me clinically how will you make out. Theory part is different.
Sir, impulse won't be continuous. There will be won't be a continuous to the parasternal impulse, and that is the LV type, sir.
What did you say?
We'll feel the apex impulse, then there will be area without any impulse, and then parasternal heave will be there. So apex and heave is not continuous, so that is a LV apex. If it is continuous, then it is RV apex.
Yeah, I think the one which you described first, there can be 3 types. One, you palpate the apex and try to track it medially, and then as you track medially, the impulse dies down and there is no parasternal lift. That is pure LV involvement. Second, as you track medially, you palpate the impulse, and as you track medially, the impulse comes down, and as you reach the parasternal region, the impulse again becomes prominent. It is biventricular involvement. And the third variety is the apex beat is continuous with the parasternal impulse, where as you track medially, there is no area in between where the impulse is less prominent, but the impulse from the apex is continuous with the parasternal impulse. That is suggestive of RV forming the apex beat. So by careful palpation, you can make out whether it is RV or whether it is LV plus RV or whether it is LV only. So here it seems that the parasternal, the apical pulsation is continuous with the parasternal lift, indicating that most likely the right ventricle is forming the apex beat. Okay, right? Yes. Go ahead.
So there is no thrill or sound palpable at the apex. And parasternal heave is present. So grade 3 parasternal heave. No thrill or sound palpable in the parasternal region.
What are the 3 grades of parasternal lift? Grade 1, grade 2, grade 3?
Yes, sir. Grade 1 is only palpable.
Yes.
But not obliterable.
Grade 1 is not obliterable.
Only palpable. Yes. So grade 1 is only palpable. So grade 2 is palpable and obliterable.
What will be everybody do not agree, but if you are telling about the grading of the parasternal lift, you must know what is in your mind. Grade 1, grade 2, grade 3. Anybody?
Grade 1 visible but not
palpable.
If at all it is very faintly palpable, but it is visible. Okay, 2.
Yes, sir. Grade 2 palpable and obliterable.
Very good. Grade 3.
And grade 3 is palpable and not obliterable.
Excellent. Very good. I think that is the accepted definition. Visible and maybe faintly palpable. 2, very easily palpable, a good lift but can be obliterated. And grade 3, the lift is palpable but not obliterable. Usually in grade 3 means there is associated significant elevation of the pulmonary artery pressure And grade 2, mostly it is related to a volume overload only. The pressure may not be significantly elevated. Okay, right. Yes, okay, right. Here it is grade 3, indicating that the parasternal lift is associated with, most likely associated with some degree of elevated pressure in the right ventricle. Okay, right.
Yes,
Go
yes.
ahead.
So S2 is palpable in the pulmonary area, sir.
Okay.
There is no thrill, and pulsations are felt in the PA.
Okay.
And RV pulsations are felt in the epigastrium.
Very good. Okay, right. Yes.
So most probably there is a we can say the RV. So RVH is there, sir, because RV is forming the apex. So right,
Yes.
RVH is there.
RV is there. RV is dilated also, because
Yes,
there is a the RV pressure is high. RV is dilated and is forming the apex. Okay, right. Yes.
And since S2 is palpable in pulmonary area, so most probably there pH is there, and grade 3 parasternal heave will also there. So
Okay,
pH,
right. What are the conditions in which you can get S2 palpable in the pulmonary area? Something is palpable in the pulmonary area. What are the conditions you should suspect?
so one is the pulmonary artery dilatation. Pulmonary
Yes.
artery.
Pulmonary artery hypertension, pulmonary artery dilatation. 1, 2.
2, sir, any if that in the
In very thin walled people, sometimes you can palpate a second sound in the pulmonary area, that you have to be careful to not interpret as pulmonary artery hypertension. Sometimes in L transposition, you may be able to palpate a sound in the aortic sound. A2 may be palpable in the pulmonary area. So that you have to be very careful. So sometimes in the examination, it may be in L transposition, and you may palpate the A2 in the pulmonary area, and that you have to be very careful. You must conclude whether it is A2 or P2 only at the end of the examination. So you have to be careful, because sometimes A2, which may be palpable in the pulmonary area, in a patient with L transposition, may create a confusion. So you should be careful. Okay, right. Okay, these are the situations in which you can hear palpate a sound in the pulmonary area. First, because of the loud P2, secondary to pulmonary artery hypertension. 2, sometimes in very thin chest wall people where the vessels are very, very close to the chest wall, that can give rise to sometimes palpable S2. And in patients with L transposition, sometimes A2 may be palpable in the pulmonary area. And here you should be careful that you are not missing a L transposition, and the sound you are palpating is not the P2, but it is A2. Okay, right. Go ahead.
sir, coming on to percussion. A left heart border at the level of apex corresponds to apex speed. Second, left intercostal space close to sternum is impaired percussion, sir. Up to 3 centimeters from the sternal borders.
Till what distance will you consider as normal?
Up to 2 will be considered normal.
Yes, yes.
Less than
1 and a half definitely, 2 borderline. 1.5 centimeters definitely can be passed off as normal. Up to 2 practically, but beyond 2 is abnormal. Okay, right. Yes.
And sir, right second intercostal space is resonant.
Okay.
So our that inspection palpation finding is now, sir, and the right heart border does extends 2 centimeters beyond the right sternal border. So there is RA dilatation, RVH, and pulmonary artery hypertension with dilated pulmonary artery, sir. Or there is a pH. Till now, this and patient in failure. With JVP, we can say patient in failure.
Okay, very good. Excellent.
These are the positive findings we can get.
Okay, from up to this stage, we have concluded that the patient is having evidence of RV dysfunction, RV failure. We also think that patient most likely has got pulmonary arterial hypertension, and the patient has got prominent A and B waves, and the right atrium is enlarged. So we have to think that probably the patient is having associated what lesion? Tricuspid, because prominent V wave and right atrium is enlarged, we have to consider a possibility of associated tricuspid regurgitation. Okay, right. Yes. Okay, go ahead.
And sir, this our left-sided that rheumatic heart is ruled out, sir. So that we can rule out. Rheumatic heart disease and other valvular pathologies we can rule out.
How can you rule out from at this stage?
Sir, RV apex
Sometimes patients with pulmonary mitral stenosis, they can present with such severe suprasystemic pulmonary artery pressure that can sometimes everything will be RV, and you may not even hear the mid-diastolic rumble. Nowadays that is not seen, but in my student period I have seen many patients in whom only you can hear the tricuspid regurgitation murmur. The mitral stenosis murmur is not audible. That is because the patient has developed severe pulmonary arterial hypertension. But if this patient does not have any symptoms of left heart symptoms, so the mitral stenosis is a very rare, very unlikely possibility. So mitral stenosis in patients who are developing severe pulmonary arterial hypertension may present with these features where the RV is forming the apex. The RV can be real parasternal lip, and even the mid-diastolic rumble may not be audible at the apex because the whole thing is right ventricle. So, but here the way we go back to the story part, I think the left heart disease is a very unlikely possibility.
No history of PND was there, sir. No history of PND was there.
Okay, right. Okay, go ahead.
So coming on to auscultation now, S1 is audible all over the precordium and best audible at the mitral area, normal in intensity. S2 is audible all over the precordium, best audible in the pulmonary area. S2 is loud and normal split. RB S3 at the tricuspid area. There is a constant ejection click in the pulmonary area. Blowing pan-systolic murmur, best audible in the lower sternal border and heard up to the apex. Increase with inspiration and passive leg raising, no radiation, grade 3/6. Shall I say the type? This is around, I think this is the tricuspid regurgitation murmur, sir.
Okay.
And so there is an early diastolic blowing high-pitched murmur in the pulmonary area, heard down along the left sternal border. Duration is more than half the diastole, increasing with 2/3 beats of passive leg rising, no change with breathing, and starts with P2, grade 2/6. So this is PR murmur, sir. PR murmur.
Okay. So let us analyze all those things. P2, S2 is normally split. What is the usual pattern of S2 split in patients with pulmonary arterial hypertension?
So narrow split, narrow should be narrow.
What is the mechanism?
So because sir, that P2 is delayed due to pulmonary arterial hypertension, the P2 is delayed. So
decrease in hangout interval because of
if P2 is delayed, then it should be widely split.
Oh, hangout.
So decrease in hangout interval due to pH.
Very good. It is decrease in hangout. Is it Aganath? What is your name?
Nikhil, sir.
Nikhil. Okay. It is because of the reduced hangout interval. Gaurav, what does that mean? Reduced hangout interval. Why the hangout interval is reduced, and when the reduced hangout interval happens, how can the S2 become closely split? Gaurav?
Yes, sir. Yes, sir. It will be yes, sir. So it will come along with the because
what is meant by hangout interval, Gaurav?
So it is the crossing over time. So crossing over time from the it is the crossing over time taken from the ejection phase to the closure of the valve, sir. It is mainly dependent upon the vascular resistance. Pulmonary vascular resistance is low. So
no, you are not defining it correctly. You have to define it correctly. What is meant by hangout interval?
It is the crossover time from the
so time interval difference between it is a crossover to closure of the valve.
Very good. So you have to be very precise, Gaurav. You make only short statements. It is a time gap between the crossover of the pressure to the closure of the semilunar valve. Pressure is crossed over. That means the pressure in the LV has fallen below that of the aortic pressure, but still the valve is not closed. And the time gap between the crossover of the LV and LV ventricular and great artery pressure to the closure of the semilunar valve is known as the hangout interval. And how can there be, why there is a reduced hangout interval in a patient with pulmonary arterial hypertension? Gaurav?
Due to increased pulmonary resistance.
Yes, when there is an increase in the pressure and the resistance to the ejection of blood, the hangout interval becomes shorter and shorter. And hence, in a patient with pulmonary artery hypertension, the hangout interval becomes significantly less than normal. And that can result in close splitting of the second heart sound. But in this patient has got a normal split. What is the explanation?
RV failure.
RV failure, RV dysfunction. Another explanation?
LV. In this case, RV failure only, sir.
Yes, RV failure. Other could be right bundle branch block. If the patient due to a disease has developed right bundle branch block, then there can be a delay in S2, and that can also result in a compensation so that the S2 can become something like a normal split. What will happen to P2 in a patient with the tricuspid regurgitation?
P2 will be early.
Will occur earlier.
Earlier. So P2 or the presence of tricuspid regurgitation also can result in a close splitting of the second heart, because the P2 can occur early, just like A2 can occur early in a patient with mitral regurgitation. P2 can occur in a patient with tricuspid regurgitation. It can occur early. While when there is a MR, there will be wide splitting of the second heart sound. While there is TR, the second heart sound can be closely split. Okay, right. Go ahead. The patient is having a constant ejection click. What do you mean by that?
So this is in PH you will have constant ejection click, sir. It will not be respirophasic.
What did you say?
It will not be in PH. There will be a constant ejection click, sir. It will not be respiratory. There is PH, so this is constant. It is not depending upon the respiratory variations. So it is.
All right. So do you think that this click is
Vascular.
aortic pressure or pulmonary pressure? Is it coming from the pulmonary artery or from the aorta?
Pulmonary only, sir. Pulmonary only.
What is the explanation why it is not? Why there is no phase signature?
So because RVDP is because
What condition do you get phasic ejection click or the ejection click?
Yes, sir. Yes, sir. Sir, valvular will be non-phasic while vascular will be phasic.
Or do you want to change the other way around?
Yes, sir. Yes, sir. Valvular will be phasic or vascular will be non-phasic. Yes, sir.
Yes. The valvular will be phasic, and what is the mechanism of phasic click?
RVDP will during aspirations, RVDP and this pulmonary area diastolic pressures will.
Sir, there will be right ventricular when there is right ventricular hypertrophy, increase in right ventricular end diastolic pressure. So in case of pulmonary diastolic pressure will be lower than the right ventricular end diastolic pressure. So in diastole, most of the time the valve will not close completely. It might remain slightly open. So that's why it is phasic.
You have to, you're right, but you have to give an explanation, not that way. You should say that during inspiration, what happens to the volume of blood coming to right
during
side?
inspiration, there is increase in the blood, so there is increase in RVDP.
Right. You have to explain that way. You have to say
yes,
that
sir, yes.
During inspiration, more volume of blood is coming to the right atrium. And even in a patient with pulmonary stenosis, when the right ventricle is hypertrophied, it is less compliant, and hence the forceful atrial contraction will result in a acute rise in the RV end diastolic pressure, which may exceed the pressure in the diastolic pressure in the pulmonary artery, and it will make the valve even open, or the valve may even dome out, and hence there is no more doming of the valve during systole, and hence the click is either absent or maybe significantly reduced. So in a patient with pulmonary stenosis, valvular pulmonary click can be phasic. It is significantly less or even absent during inspiration and is audible during expiration. In a patient with pulmonary arterial hypertension, when there is a click, what is the nature? Is it phasic or non-phasic?
It is non-phasic, sir. Non-phasic.
Why it is non-phasic?
So because the pressure is increased, sir, so it will not be coming down to RVDP, sir.
Yeah, very good. In a patient with pulmonary artery hypertension, the pulmonary artery diastolic pressure is so much elevated that RV EDP cannot exceed the pulmonary artery diastolic pressure. So it will not have any effect on the pulmonary valve. So the phasic ejection click occurs in patients with pulmonary stenosis, and non-phasic ejection click occurs in patients with pulmonary artery hypertension. Why there is a click in pulmonary artery hypertension when there is a vessel is dilated?
Due to flow of the.
What is the mechanism of click? Mechanism of vascular click?
Yes, sir. So it is pulmonary arteries are dilated, sir. So when it is going from flow.
Sir, there is post-stenotic dilatation, sir. So the opening of the wall, normally when the walls open, the sound is not we are not able to hear the sound. But when there is a post-stenotic dilatation, that sound will resonate, and that's why we will be able to hear the sound, sir.
Very good, excellent. I think you are very good understanding. Excellent, very good. I think when in a patient with a vascular click, it is usually occurs when the vessel is dilated. When normally when the semilunar valve is open, then still there is a small noise produced, but the noise is so feeble that it is not audible for human ears. But in a patient with where there is a dilated vessel following the valve, sound can resonate in the dilated vessel and it becomes audible. So that is why in patients with aortic dilatation, aortic aneurysm, all these situations you can hear a vascular click. There can be a vascular click because of the resonance of the sound generated by the opening of the valve. I think very good, excellent. I think you have got a very good understanding. So here this is a constant click, and we think that it is a vascular click. Okay, right. Go ahead. Yeah, blowing.
Yes, sir. The blowing pansystolic murmur best audible in the lower sternal border and heard up to the apex. Increase on inspiration and passive like rising no radiation rate 3/6. So this is TR, most of the TR murmurs.
Okay, very good. Yes.
And
yes.
Yes, sir. And there is a early diastolic blowing high-pitched murmur in pulmonary area heard down along the left sternal border during duration more than half of the diastole, increasing with 2-3 beats of passive leg raising. No change with breathing, starts with P2. Grade to those PR murmurs. Pulmonary gastro.
Why did you say it's TR murmur? Why the murmur is not changing with breathing? It's a right-sided murmur. Why it is not increasing on breathing?
So with 2 to 3.
There is a leg raising.
Yes.
RV failure.
RV failure is there. RV failure.
So what?
RV failure. So
what is the explanation that in a patient with PR, the murmur may not increase on inspiration?
So, due to RV failure, already so much blood is there in the right ventricle, so extra blood is not able to.
So that applies for tricuspid regurgitation also. When during inspiration, when more volume of blood coming to the right ventricle, what will happen to right ventricular pressure?
It will increase.
It will increase. When the right ventricular pressure increases, what will happen to gradient between the pulmonary artery and the RV?
Gradient will decrease.
It will decrease. So what will happen to PR? PR may decrease.
Yes.
Actually, unlike tricuspid regurgitation, the PR murmur may not change at all during inspiration. That is because a large volume of blood coming to the right ventricle during inspiration can result in a higher RV diastolic pressure, and hence the pulmonary regurgitation may not significantly increase, or even it may even decrease. While tricuspid regurgitation is different, where during systole, when the RV is ejecting the blood, a larger volume of blood, there will be more tricuspid regurgitation and the murmur will be louder. So pulmonary regurgitation murmurs may not increase during inspiration, while tricuspid regurgitation murmurs will always increase. Okay, right. Okay, go ahead.
So abdominal examination, liver is enlarged 4 centimeter below the thoracic cage. Tender, no splenomegaly, no free fluid in abdomen. Respiratory system, no abnormalities detected.
Okay. So what is your provisional diagnosis?
Yes, a provisional diagnosis, 29-year female, postpartum 1 year. With now, sir, will give, sir, right-sided failure secondary to pulmonary arterial hypertension severe, because I am giving severe because P2 is palpable, and there is a grade 3/3 parasternal heave is there.
Okay, very good.
With features of CCF and now in NYHA class 3, sir, sinus rhythm, and no.
What is the cause of PH?
PH, sir, most probably
Idiopathic. You think that is most likely it may be primary pulmonary arterial hypertension. Okay, right. We'll go to the ECG. What do you like to see first? What, ECG or X-ray chest?
The X-ray chest, just X-ray, sir. Just
like to see X-ray. Why do you want to see X-ray chest first?
So because patient already in sinus rhythm, sir, and X-ray I will be able to see the that PA segment, pulmonary segment, and RA delta.
Okay, let me see. Nice one. Okay, you want to see the X-ray. Okay, this is the X-ray.
Yes, sir. The X-ray chest PA view.
Oh.
Sir, normal is normal penetration. Sir, normal penetration, slight rotation to the left, sir. Nothing else.
Okay, very good. There is a minor rotation to the left. Okay, very good.
Yes, sir. Coming on to the cardiac, cardiomegaly is there. Sir, CT ratio around 55 to 55%. Cardiomegaly.
Okay, very good. Very good.
And coming on to the apex, sir.
No, left side of the heart.
Yes, sir. I'm coming on to the.
Okay, you want to see about the apex. Okay, right. Apex.
Yes, sir. I'll go from down to up, sir.
Okay.
Sir, coming on to the apex of the heart, sir, I'm not. Most probably it can be RV type or LV type also, because it is coming down also. So apex not very good.
I will pass it up as normal. I cannot make a comment whether it is RV or LV type. Okay, very good.
And sir, main pulmonary artery segment is enlarged, sir.
Very good.
And main pulmonary artery segment is enlarged.
Right atrium.
Right atrium. Actually, it is just two sternal borders, sir. So right atrium. I'm not.
Okay.
Right atrium
it will not be enlarged. It does not satisfy. How will you diagnose right atrial enlargement in the X-ray chest?
Sir, more than 5 centimeters from the this mid-sternal line, sir. More than 5
that is applicable when you are taking an X-ray chest in the standard format, where the distance the X-ray is taken in a full plate. The distance is 5 to 6 feet from the source to the patient, and in that one, when you take the measurement, if the right border is 5 centimeters or more from the mid sternum, that is indicative of right atrial enlargement. Here, this can be interpreted as in what way? You again take the measurement from the mid sternum to the right border of the heart, and this distance, if it is more than 1/3 the right hemithorax, that also is a point in favor of right atrial enlargement.
But it is not significant. Here it is not significant.
X-ray wise, there is no right atrial enlargement. Or you can also apply the vertical criteria. What are the vertical criteria for right atrial enlargement?
So more than half of the.
More than 2.5 intercostal space.
Yes, one is more than 2.5 intercostal spaces, or more than
half of the interthoracic vertical line from the.
More than half of the right border, vertical height, is formed by the right atrium. Or you can also say that if the right atrium covers more than 3 ribs, If it is covering more than 3 ribs, that also is a point in favor of right atrial enlargement. Here it is borderline. I would also agree with you that if you say that there is no definite evidence to diagnose right atrial enlargement in the X-ray chest, I will agree with that. Borderline, because 1, 2, 3 is there. If you want, you can put it as mild right atrial enlargement. Left atrium.
So cranial angle appears to be okay, sir. So cranial angle is
The
not widened.
cranial angle is normal. So and also I am not definitely seeing any shadow through shadow. Left atrial appendage is not prominent. So all put together, there is no X-ray evidence of
enlargement.
enlargement. Okay, right? Yes.
And sir, I am also not seeing any signs of PVH, sir, because lung fields are appears to be.
There is no evidence of pulmonary venous hypertension because some vessels are not prominent. Yes. Any evidence of pulmonary arterial hypertension?
So main pulmonary artery is dilated.
No, main pulmonary artery is dilated. Yes. What are the cause of main pulmonary artery dilatation?
One is pH.
pH.
Increased flow.
When you see a pulmonary artery is dilated, what are the conditions which should cross your mind?
Post-stenotic dilatation.
Post-stenotic dilatation. 4 conditions. So you must realize this is.
So any increased flow?
Yes, increased shunt lesions. Okay, shunt. And also idiopathic dilatation of pulmonary artery. So whenever there is a pulmonary artery segment prominent, you should think of one of these 4 conditions: increased flow, increased pressure, post-stenotic, and idiopathic dilatation of the pulmonary artery. So one of these 4 should be there. So here, what is the reason?
Increased pressure.
Why?
pH, idiopathic pH.
What is the evidence of pH in the X-ray chest in this patient? What is the evidence? What is the evidence of pH in the? What is the? How will you diagnose pulmonary hypertension by looking at the X-ray chest?
The main pulmonary
peripheral pruning.
Peripheral pruning. This is known as centralization. The central vessels are large, but as you go to periphery, they just suddenly cut off, and there is no peripheral flow at all. That is suggestive of pulmonary arterial hypertension. Here is and also the pulmonary artery branches will be dilated. Is there any enlargement of the right pulmonary artery?
No, sir. No.
It is not enlarged. So from the X-ray chest, it is difficult for you to diagnose pulmonary arterial hypertension in this patient. And there is there is no centralization. The central vessels are not very large. But I agree with you that there is a relative oligemia or relative reduction in the vascularity as you go to the periphery. But that is not very striking. So from the X-ray chest, it is very difficult for you to make a diagnosis of pulmonary arterial hypertension, accepting that pulmonary artery segment is dilated. Main pulmonary artery is dilated. Okay. Now we'll go to the ECG. Okay, ECG.
So ECG is right around.
Oh. Can you see the ECG?
Yes, sir. Sir, rhythm strip is what? Rhythm strip.
And there is no rhythm strip. You are only 12 lead electrocardiogram.
Yes, sir. 12 lead ECG, sir. Normal centralization and calibration, sir. I can see that sign there. And so coming on to the P wave morphology, so P wave are positive in lead 1, 2, 3, and AVF and negative in lead AVR. So it is a sinus P wave with normal axis.
Very good, excellent. Okay.
And there is in sir lead 2, sir. I can see there is a peak pulmonale is more than 2.5.
Borderline. I agree with you. There is a borderline peak pulmonale. Okay, right. Very good. Yes. Maybe just 2.5. Maybe. Yes. All right.
And so axis is lead 1 is equiphasic, sir. So axis around plus 90. Right, axis around plus 90. We can lead 1 is equiphasic. So I'll take axis around plus 90 to 100.
Okay, between 90 and 100, 90 and 120 maybe about, because say the lead one is more negative and AVR also is more negative. So there will be a transition is between lead one and AVR. So access will be near about 100 plus, 105.
Around that. Yes,
okay, right. Yes.
Coming on to the sir, QRS is narrow QRS.
Okay.
Heart rate, I forgot.
Is there evidence?
Around 60 per minute. Heart is around 60, sir.
Okay.
60 per minute.
Near about 60, 65. All right. Okay. Yes.
And sir, there is so there's features of right ventricular strain because there is a QR pattern in V1, sir.
Okay. What does that mean? QR pattern with
ST pressure.
There is a STT change. What does that mean?
Sir, RV strain.
RV strain. What does that mean? RV pressure may be
raised RV pressure.
Okay. Yes.
And sir, here we can say that it is around. We can also say the pH is because RV pressure is around. This is around 2 boxes, 10 into 5, around 50, sir. Pulmonary artery pressure is around 50.
There is a calculation by looking at the electrocardiogram because you take the height of the R wave. R wave, I forgot that formula because they multiplied by 7 plus 10, something like that. I will tell you next class. There is a formula by means of which you can calculate the RV systolic pressure by looking at the R height in V1.
So it is around 50 to 60, 50 to 60.
But here, actually, whenever you find that's a QR pattern with STT change, that is more likely that the
suprasystemic
pulmonary suprasystemic pulmonary pressure, which could be anywhere between 110 to 120. So this was most likely this patient must be having suprasystemic pulmonary artery pressure.
So our findings are confirmed.
No, before that, what are the three electrocardiographic criteria for the diagnosis of right ventricular hypertrophy?
The first is the right axis deviation.
Yes, all should have right axis deviation. 1, 2.
2, sir. This RS ratio is more in V1 and V2, sir. R to S ratio is more in V1 and V2. R is more than S.
Yeah, or QR pattern or pure R pattern or a prominent R wave with some degree of S wave where R by S ratio is more than 1. This usually indicates systolic hypertension. Okay, right. Okay, right. Yes. Systolic hypertension resulting in pulmonary arterial RVH. Okay. Third, second variety.
It is RSR pattern also.
RSR dash pattern. It's more like a volume overload pattern as can happen in patients with shunt lesions, ASD and all. And here, what is the criteria?
RSR more than 11, they are telling. More than 11 mm is...
what should be the height of the R wave?
7 or 7?
Yes. If the height of the R wave is 7 or more, and R dash wave?
More than 11, sir. R dash more.
11 or more, or some people say even 15. So definitely more than 11 may be a borderline situation, and 15 or more is definitely RVH. Okay, right. Yes. Right. The third criteria?
QR is...
Third criteria. Anybody? Any one of you? Saroj, would you like to try?
Yes, a persistent of S wave in the V5, V6.
Very good. R by S ratio in V5 or V6 less than 1. R by S ratio in V5 or V6 less than 1. So right axis deviation and R by S ratio, R by S will continue from V1 to V6 and R by S ratio is less than 1. And what condition do you get this?
COPD, sir.
COPD. Very good. COPD. So these are the three things you should remember. One, right axis deviation should be there in all three criteria. But then if there is a QR pattern, pure R pattern or R by S less than 1, usually associated with systolic pressure overload of the right ventricle. As can occur in patients with severe PAH. Two, R dash pattern where initial R is equal to or more than 7, more than 11 or more than 15 is definite, but more than 11 also can satisfy the criteria. And this is usually associated with volume overload, as can occur in patients with atrial septal defect. Third one, R by S ratio less than 1 in V5 or V6. The pattern of R by S continues from V1 to V6. In this case, this is associated with right ventricular hypertrophy, as can occur in patients with COPD. So these are the three criteria. Okay, right. So this patient has got right ventricular hypertrophy with most likely suprasystemic pulmonary artery pressure. Okay. So
with RVH is also
yes.
RVH.
Okay.
Our findings are confirmed, sir. Findings are confirmed by
yes. Our findings are consistent with our diagnosis.
ECG.
Okay. Yes. Now coming to the echo.
Yes, sir. First, sir, left upper, sir, parasternal long axis view with. So we can see that we can see that interatrial septum is bulging towards the left side, sir. So increased pressures on the right side we can see from this.
Interatrial septum.
Interventricular septum, IVS, interventricular septum, interventricular septum.
Interventricular septum is there is a reverse Bernheim effect, and interventricular septum is moving with what? RV or LV?
Moving with moving with RV, sir.
Moving with RV. The interventricular septum is bulging to the right LV, and
RV is dilated as well.
This RV outflow is dilated.
RVOT
is dilated. Okay, right. Yes, go ahead.
Oh, sir, that apical four-chamber view, we are not, sir, that's like.
No, yes, this is a short axis view.
No, last previous slide there was there, sir.
There was no apical four-chamber view.
Okay. Nothing. Okay.
Or parasternal long axis view only.
Okay.
They're all parasternal long axis view. There is no MR, there is no AR.
Okay,
right now we'll go to this one.
There is no AS also. There is no AS.
What does it show?
So it shows that D sign of D sign.
Yeah, D sign. What does D sign mean?
So that PA pressures are suprasystemic.
Yeah. If the D pattern is seen both during systole and diastole. Here mostly this D pattern is seen during systole as well as diastole. Usually the severe pulmonary artery hypertension could be suprasystemic also. Okay, right, yes. So here is a D sign, very good. Yes. What else?
And sir, ejection fraction is normal, sir. EF is around 61%. I can remember.
Okay, so normal LV function seems to be all right. Okay, right. Go ahead. We'll go to the next one. What is the next to this one show? The second one.
So pulmonary regurgitation.
Yes, pulmonary regurgitation. Yeah. Pulmonary regurgitation. And that is recorded in the continuous wave Doppler.
Yes.
And by looking at the pulmonary regurgitation pattern, what are the pressures that you can derive? Gaurav?
So, yes, sir, we can derive the RV.
We can derive
systolic pulmonary artery systolic pressure. We can derive the pulmonary artery.
How?
So mean and
diastolic.
Yeah, mean and diastolic pressure can be derived directly by looking at the regurgitant velocity. The initial part of the regurgitant velocity will give you the main pulmonary artery pressure, and the end velocity will give you the diastolic pulmonary artery diastolic pressure. By getting these views, these two, can you calculate the pulmonary artery systolic pressure?
Yes, sir. Yes, sir.
How?
The pulse pressure that we can mean and 2/3. Mean plus 2/3 is Mean plus 2/3.
Yes. How will you calculate the pulmonary artery systolic pressure when you have got mean pressure as well as diastolic pressure?
The mean pulmonary artery pressure is equal to diastolic pressure plus 1/3 of the pulse pressure.
Very
And
good.
sir, pulse pressure is systolic minus diastolic.
Yes, very good. So if you find out the difference between the diastolic pressure and the mean pressure, multiply it with 3 and add that to diastolic pressure, that will give you the systolic pressure. To quote an example, suppose the diastolic pressure is say 80 and the mean pressure is 90. So pulse pressure is 10. 10 into 3 is 30 and 80 plus 30 will be 11, 110, and that will be the systolic pressure. So by getting the mean pressure and the diastolic pressure, you can calculate roughly what will be the systolic pressure. Okay, right.
Systolic.
Yes. Now we'll go to the, okay, right. Yes. Your apical four-chamber view, all those things are there. Interpret.
Yes, sir. Yes, sir. Coming on to the apical four-chamber, so left down, sir. RV is forming the apex, sir. We can say now. RV is dilated, RV is dilated, and RV is forming the apex.
Very good.
And sir, there is coming on to color, so there is moderate TR, sir. Moderate, around moderate.
Very good. Very good.
With TR velocity is around 5, so maximum pressure is around more than 100. So suprasystemic pH.
Very good. So, what about RV function?
So TAPC you have not. Without TAPC.
Good.
What did you say? Good.
Sir, because sir, tricuspid regurgitation. Sir, from tricuspid regurgitation also, sir. Otherwise, if it is not functioning well, then sir, it will be a low pressure TR.
Point is certain. Okay, let's see whether there is a. Oh yeah, it is here.
So without TAPC, can we say that? Otherwise, we have to see the RV EF more than 35%. Then only we can.
Sir, TAPC is 11. So
TAPC is given here.
TAPC is 11, sir.
Okay.
So it is a dysfunction is there.
So there is very significant. What is the normal TAPC?
More than 17.
More than 17. Equal to or more than 17.
16, 17.
No, up to below 17 is abnormal. 17 and plus is normal. You said about ejection fraction 35%. You are wrong. What is the correct statement?
RV ejection more than 30.
No, wrong. You have to make a correct statement.
Fractional shortening. RV fractional shortening, sir.
Yes, fractional area change, not fractional shortening. Fractional.
Area change. Area change.
Area change. It is FSC, fractional area change, where you look at the area of the right ventricle. When right ventricle focused view during systole and diastole, and if it is the systole is smaller by more than 35%, then you can say that it is a normally functioning RV. Even though the TAPC is the simplest and easy to perform, FAC is a little more reliable. So if you want to do, if you are in doubt, you should do FAC also, fractional area change, not ejection fraction, fractional area change. What is the normal ejection fraction of RV by 3-dimensional echocardiography?
More than 35.
No, wrong.
40.
No. More than what? No. Somebody said the correct answer. More than?
45.
More than 40. More than 45. So ejection fraction is more than 45. So, okay, right.
Yeah, the IVC is dilated, sir, too, and it is not, there is no variation also. So.
Okay, that also indicate that there is a, what does that indicate? What does that indicate?
RV failure.
Don't use the word RV failure. It indicates the right atrial pressure is
enlarged. That means it increase.
Studies have shown that it is more than 15 millimeters. Whenever there is no collapse and the IVC is distended and there is no collapse, then the right atrial pressure is around 15 or more, 15 millimeters or more.
Yes, sir. And now, our also V wave was around 14, so it is okay, sir. It is.
Yes. Okay. Right. Okay.
Yes, sir. Next.
Okay. Any comments?
Mild.
Nothing special. So what is your diagnosis? Final diagnosis?
Yes, sir. 29-year female, sir. Postpartum 1 year with now with idiopathic severe PH, moderate tricuspid regurgitation, moderate PR, RV dysfunction, heart failure, normal sinus rhythm.
Okay. So when will you diagnose pulmonary hypertension?
So mean pressure more than 20, sir. Now they have changed to mean pressure more than 20.
Oh, have they changed to 20?
Yes, sir. Yes, sir.
Originally it was 20, then they moved to 25, and now they come back to 20 because the normal pulmonary artery pressure is mean is around 18, and if it is more than 20,
no, they have changed, sir. Changed. 2020 they have changed.
No, this is then this is the more correct one. This I have taken from 21 or 22. So, few points about pulmonary artery hypertension. Pulmonary artery hypertension can be pre-capillary and post-capillary. How will you differentiate?
Yes, sir. Yes, sir. So, depending upon this pulmonary capillary wedge pressure, sir.
Yes. How will you differentiate?
Sir, if pulmonary capillary wedge pressure is less than 15, sir. Pulmonary capillary wedge less than 15.
15 in what?
In 15 millimeter of Hg, sir.
Yes, in pre-capillary.
Yes, sir, pre-capillary.
Post-capillary, it will be more than
15.
15. And what will be the transpulmonary pressure gradient?
Sir, few books writing more than 7 also, sir. More than.
Normally, it is only 7 to 8. But when you want to think of a pathology, it should be slightly more. Normally, it is only 7 to 8. The pressure drop is usually around 7 to 8 millimeters of mercury. But 8 to 12 is considered as borderline, and more than 12 is definitely suggestive of reactive pulmonary artery hypertension.
Yes.
What are the pathological changes of pulmonary artery hypertension?
So, 4 grades, sir. You mainly involves the vessels less than 500 micrometers in diameter. Grade 1 is medial hypertrophy. Grade 2, intimal proliferation. And fibrotic change is grade 3 is adventitial thickening with moderate perivascular inflammatory infiltrates, and grade 4 is complex lesion like plexiform and dilated lesions, ruptured vessels, and thrombotic lesions. Yeah. So the pulmonary artery hypertension can progress through the 4 pathological changes. Grade 1 is only just medial hypertrophy. Grade 2 is intimal proliferation, and associated with there can be some fibrotic changes. Grade 3 is adventitial thickening with moderate perivascular inflammatory infiltrates. And grade 4, complex lesions like plexiform, dilated lesions, ruptured vessels, and thrombotic lesions. The grade 4 changes are restricted to what forms of pulmonary artery hypertension? Does it happen in patients with mitral stenosis? Does complex lesions like plexiform, dilated lesions, ruptured vessels, thrombotic lesions, does these lesions occur in patients with mitral stenosis? Something has happened to your connectivity. You are not clear now. You are not audible, you are not clear.
So these are more common with
mostly
the
to pre-capillary, sir. This is not.
Yes, in occasion pre-capillary, but I am asking you a question. In which type of pulmonary artery hypertension you get grade 4 changes?
The primary pulmonary arterial hypertension.
Very good, primary pulmonary artery hypertension and Eisenmenger syndrome. These are the two situations. These are the two situations where there can be the grade 4 changes. Usually, pulmonary hypertension secondary to conditions like mitral stenosis. the post-capillary pulmonary artery hypertension, they usually do not go in for grade 4 changes. Okay, right? Yes. So when you classify quickly grade 1 pulmonary artery hypertension, which includes all idiopathic, the heritable, drug or toxin induced, associated with congenital heart disease, connective tissue disorders, all come under that category. Grade 2 pulmonary hypertension due to left heart disease. Probably this will be the commonest cause of pulmonary artery hypertension, where the left heart disease leads to pulmonary artery hypertension. Grade 3 pulmonary artery. Yes.
Sir, in that recent CSI, in the recent CSI update, they have written that post-infective obliterative hypertension is the most common cause in India, sir. That CSI update they have written.
Studies done from Trivandrum, where they have looked at all patients with pulmonary artery hypertension. They found that the commonest cause is actually a left heart disease leading to pulmonary artery hypertension. But if you are excluding the
yes, sir, that flow Kerala registry, sir.
Beg your pardon?
That Kerala registry you're talking about, sir.
The Kerala registry.
Kerala registry was there, no, sir, that findings.
In Kerala registry.
But sir, in that recent, that yesterday, day before yesterday, yes, sir, in that CSI update, they have written, sir, that recent CSI update came, sir. There they have written that post-infective obliterative is the most common cause of PH in India. That yesterday I was reading, or day before yesterday. That
I have not read that, but the study.
That CSI update 2021
has shown that if I look at my personal experience, I would also consider that patients with left heart disease developing pulmonary artery hypertension is much more frequent than patients coming with pulmonary artery hypertension, mitral stenosis, rheumatic heart disease, dilated cardiomyopathy, myocardial infarction. All those patients who develop pulmonary artery hypertension are secondary to left heart disease. But if you look at patients coming with primary pulmonary artery hypertension, Eisenmenger syndrome, the number is not very large. And I do not know whether the arterial occlusive disease secondary to something like vasculitis is the leading cause of pulmonary artery hypertension. You need more evidence. It is very difficult for me to accept immediately, because we are seeing regular patients with pulmonary artery hypertension, and majority of patients have got a left heart disease. Of course, some of these patients with the left right shunt lesion can present with pulmonary artery hypertension. And then PH due to lung disease is another cause. Then pulmonary arterial embolism and pulmonary hypertension due to unclear or multifactorial causes, which may also include vasculitis. When you come to the treatment part, the patients with the vasoactive pulmonary hypertension can benefit by calcium channel blockers, especially the studies with nifedipine has shown that these patients respond to nifedipine very well. How will you assess vasoactive pulmonary hypertension, Gaurav? How will you?
Yes, sir. By invasive hemodynamics, sir, the pressure is reduced to less than 10 millimeters and up to 40 millimeters, sir. That is.
No, the drop should be more than 10 millimeters of mean pulmonary artery pressure, and absolute value should be less than 40 millimeters. The drop should be more than 10, but it should fall below 40 millimeters of mean pressure. Then that will qualify for. What are the vasoactive interventions that you do?
Calcium channel blockers.
No. When you do in the cath lab, what is the process by which? Adenosine is all right. But the most ideal is nitric oxide inhalation. Nitric oxide is the best one. Then oxygen inhalation can be tried. Then isoprenylene can be used. Adenosine can be used. And all these by interventions, you should be able to demonstrate a fall of more than 10 millimeters mean pressure, and it should fall below 40 millimeters of mean pressure. Both criteria should be satisfied. There should be a drop of more than 10 millimeters of mercury, and it should drop below 40 millimeters of mercury mean pressure. Then there are many other drugs which can be used for the treatment of pulmonary hypertension. Another is prostacyclin modulation. Drugs which can be used are intravenously. Certain prostanoids can be used. Inhalation, treprostinil can be used, but recently Selexipag has been introduced, which is an oral preparation and which has already come to India. So Selexipag becomes a very useful drug in order to bring down the pulmonary artery pressure in patients with severe pulmonary artery hypertension. Other drugs include endothelin-1 receptor antagonists like bosentan, ambrisentan, and macitentan, or it may be phosphodiesterase enzyme inhibitors like sildenafil or tadalafil, or maybe soluble guanylate cyclase stimulator, riociguat, which increases the sensitivity of soluble guanylate to nitric oxide. Sometimes, many times you may require combination treatment, but you cannot combine 5 and 4. That is they cannot be combined. But 5 can be combined with 3, or it can be combined with 2 also. But 5 and 4 cannot be combined. And sometimes in these patients who are not responding to any of these medications, sometimes you may require an interventional treatment, which include atrial septostomy. There are few investigational drugs which have not yet been come into the market for use in the treatment of patients. Drugs which have anti-inflammatory and antioxidative properties, and sometimes drugs which can target the immune system in pulmonary hypertension. Some of these drugs which are still in the developmental stage can be used, may come into market at a later stage, but at the moment they are still in the investigational stage. There are a few prognostic indicators of pulmonary arterial hypertension. They include clinical signs of right heart failure. If the patient is a right heart failure, they have got a very bad prognosis. Progressive symptoms that indicate very bad prognosis. If there is history of syncope, especially multiple episodes of syncope, is a very bad prognostic point. Functional class, if the patient is class 3 or class 4, they have got a bad prognosis. A 6-minute walk test, if it is more than 140 meters, or then they got a good prognosis. If it is less than 155 meters, then they got a bad prognosis. Cardiopulmonary exercise testing, NT-proBNP plasma levels, imaging, hemodynamics, all can be used to assess the significance of what is the prognosis in these patients. One single point which is most important is RV function. If the patient is having associated RV dysfunction, and those patients have got a very bad prognosis. All the other indicators are mainly measured to predict the RV function. If the RV dysfunction is there, those patients have got a bad prognosis. So that's what you should look at. If the patient is having right atrial pressure of more than 15 millimeters of mercury, they have got a bad prognosis. So in our patient, what is the prognosis, Gaurav? What is the prognosis in our patient?
Bad prognosis, a bad prognosis.
Why did you say bad prognosis?
Bad prognosis. So there is history of syncope, there is RV dysfunction, right atrial pressure is more than 15.
Yes, there are multiple
Everything
points.
is there.
Multiple points, we can say that the patient has got a bad prognosis. What about pregnancy in these patients? Pregnancy.
So no more pregnancy, sir. No more pregnancy.
Yes. Pregnancy is contraindicated in these patients. These patients can result in a very progressive increase in pulmonary artery pressure, and that can result in fetal loss as well as maternal loss, and pregnancy is contraindicated in these women. So pulmonary artery hypertension, a lot of new things are coming up, especially in the treatment of pulmonary artery hypertension. And we are seeing more and more patients with pulmonary artery hypertension, and some of them have got a vascular response, vasospastic pulmonary artery hypertension. They may respond to nifedipine. And for patients with pulmonary artery hypertension, for 5 groups of drugs are available, and any of these drugs can be used, and drugs can be used in combination. It's better to combine 2 drugs and 2 groups of drugs, and so that the response will be better. Okay, any doubts about pulmonary artery hypertension, you can ask.
So like renal denervation, pulmonary denervation is also tried.
Pulmonary artery denervation, is it beneficial?
So it's still not very good. So it has come in our update.
Oh, how do they do it?
Radio, some catheter they take into the pulmonary artery, and then they do the adventitia or the adventitious nerves. So they radio frequency ablation. So like in case of renal artery.
What are the complications? Because the phrenic nerve is very close to it. Is there a risk of damage to phrenic nerve?
Sir, I don't know the detail, but sir, in update, sir, they have given. Sir.
The ablation of the venous nerves of the pulmonary artery.
Yes, sir. Yes.
Okay, I'll read through that and find out what is happening. Because unlike the renal artery, which is a very small vessel, it may be very difficult to ablate the nerves of the pulmonary artery. May not be that easy. And also we should look at whether there can be any complications also. It is still in the must be in the experimental stage, may not have come out into the patient management.
Yes, sir.
Okay, any other doubts? Any other statements?
The balloon atrial septostomy.
That is only a palliative.
Palliative, sir. Yeah, yes, yes.
One treatment that you can think about is that surgical treatment, wherein patients with thromboembolic pulmonary arterial hypertension, you can do an endarterectomy, and many patients can improve with the surgical endarterectomy. Okay, if there are no more doubts, I think we will stop at this level. And what do you like to have next week? You would like to have another case, or you would like to have some spotters? The one or you like to have a case? Okay, I'll bring a case. Can any one of you bring a case so that we can make the discussion more lively? If there are none, I will bring a case, no problems. But if any one of you is having a case, you bring that case also, so that we can discuss that case. Nathan, will you be able to get a case? Nikhil?
Sir, if I'll get, I'll let you know, sir. Okay. If any good case is there in our hall.
You try to bring, you let me know.
Sir.
Otherwise,
yes,
I will
sir.
bring a case. Okay.
Yes, sir. Yes, sir.
Okay, right. Okay, next week, so we'll have a case discussion, and I will definitely bring a case. And if anybody is having a case, you bring it, and Nikhil may try to bring a case, and yes, then sir, we'll have a discussion on that case also. Okay. Okay, thank you. Good night. Good night.
Good night.
Good night.
Thank you, sir.
Good night.
Thank you very much. So from here, I'm ending this meeting. Thank you very much, everyone.
Thank you. Thank you. Thank you.